was super helpful to everyone. It was a great day, but as we know, that's a little challenging to do in 2020. But we are trying to make sure that everyone can get the information that they need and have these opportunities virtually. I am going to pull up my screen real quick and then walk through some administrative items and kick us off. All right, so let's see. We are in, you probably noticed, in webinar mode. What this means is, unfortunately, participants cannot speak or share their screen right now in webinar mode. However, this event is meant to be interactive. So how we're going to try to accomplish that. If you have a comment that you want to share, you can use the chat feature. If you have a question that you want to ask, you can use the Q&A. We will be paying attention to that Q&A. This is not meant to be our speakers speaking and attendees just listening. Again, it is meant to be very interactive. So we can't stress that enough. We know it's a little intimidating. It's a big group that's going to be joining. Looks like we have about 47 people so far, but there's quite a few people signed up. So we know that can be intimidating, but try not to let it intimidate you from making your comments. You can even use a feature where you can keep yourself anonymous if you want to. So if you want to ask a question, but you weren't sure that you wanted everyone to know it was from you, don't let that intimidate you either. So with that, I am going to introduce the panelists that you have today. So for those I have not had the opportunities to meet, I am Lauren Shea. You may know me as Lauren Rose. I did get married in September. I am with Kohler Healthcare Consulting, and I'll be one of the panelists this morning. We also have Jennifer Gardiner. Say hi, Jennifer. You probably know Jennifer as well. She is wearing two hats right now. So she is Director of Revenue Integrity for UMS, but also serving as the newly appointed Chairperson for the HSCRC Clinic RVU Task Force. So we'll probably include some updates from that task force during this morning's session. And then we also have Caroline. Caroline, say hi. For those that don't know Caroline's with CohnReznick, which I think is a change from last year. Right, Caroline?
It is. I actually started with CohnReznick the day that everybody went into quarantine. So interesting timing.
I'm sure you planned that.
Right.
So the three of us, again, for those that we have not yet met, just so you know, we're not shy. So we're definitely going to try to keep this morning's conversation going. Our plan is to talk about these challenges until about 10:30. But what was also exciting about today is this is going to be our first virtual networking event. You may remember that last year in the in-person event, we spent a lot of time going over technical details and having great discussions, but we also used it as an opportunity to network with each other. As you're going through these updates for January 1st, it can feel like you're all alone and you're trying to figure all these things out, and you've got all these questions and you want to know how other folks are handling it. So that's another key piece of this group, was networking. And Caroline, I was hoping you could just kind of give the group a little bit of updates of how that's going to work. And you, of course, are the guinea pig rolling out this networking. So no pressure, Caroline.
No pressure, no worries. So one thing this group has learned, and we all agreed, is 2020 has definitely thrown us a lot of different obstacles. And we've been very nimble and flexible and making everything work. So some of you may have received an email about downloading an app called Goose Chase. We realized very quickly that we outgrew our number of licenses and the ability to expand that. So we took the Scavenger Hunt and we put it into SurveyMonkey. And you should have the link to that from the email that was sent out this morning. It's the same Scavenger Hunt questions. And as soon as you sign into the survey, it's going to ask for your information and you can start entering some of the answers, which you'll find clues within the presentation to many of these, but there's also items there that we want you to share your own personal gifts, talents, perspectives as well. There's a total of 13 questions. They will be tallied at 10:45. So you'll see we go into our networking session at 10:30. You'll have a little bit of time in between to get adjusted, to get some final changes. And then we'll use some of those answers also as icebreakers. So behind the scenes, we have some, since it's Christmas time, we'll say little elves working behind the scenes to tally the results, as well as they're going to be sending me some information to really get that networking discussion going. So everyone gets to have a chance to learn a little bit more about each other, as well as we'll have some discussion topics to go through. So really looking forward to that, to the time. And I want to come out of this as the guinea pig saying that we did it. So please plan to participate.
Right, and bear with us if we have Zoom challenges when we're trying to do all that networking, because again, this is our experiment. And we just threw Caroline into that. I believe you were voluntold to do it. So
no worries.
Our full bios are in the presentation. We are not going to walk through those. All right, so what are we trying to do this morning? We are, again, doing a part 2 deeper dive. Hopefully, many of you were able to attend the session on November 13th. That one was a Region 4 webinar, just walked through the January 1 updates from a very high level perspective. But we thought this part 2 would be helpful for our Maryland folks or other individuals that are interested in some of the Maryland uniquenesses. To do a little bit of a deeper dive, see if we have any concerns coming up this year with HSCRC reporting, system implementations, and some of the other go lives that are happening January 1. So that's our goal. We are open to any topic that anyone in the group wants to send our way. We're going to walk through the presentation. If we're not receiving input from members of the audience, we'll keep going through the presentation. But again, we really hope that our participants, looks like we're over 60 people now, we're really hoping that you will participate. Don't be shy. If you are new to all this January 1 stuff, new to the HSCRC reporting, there is no question that we're going to say, oh, I can't believe you asked that question. This is a safe space. So we hope you'll, make some connections today, even if it is virtually, and learn some information to bring back to your positions. Oh, disclaimers. Yeah, we like to have disclaimers. First of all, the conversations that we have today could just be Jen, Lauren, and Caroline voicing their opinions. So you should make your own decisions regarding system updates. We apologize in advance if we should start venting about a particular topic. Again, some of the information we share will be our opinions. Also, today and the event on November 13th are not a substitute for actually reviewing the changes in the CPT professional manual. Again, you should not just go off of highlights of what you heard when you're updating your systems. That manual doesn't just list the codes, it also lists lots of explanatory notes, so it's a really important resource. And when we talk about codes, remember that just because a service has a code does not mean it's covered. So we could be talking about some services today that sound wonderful, but guess what? No one's paying for them. So keep that in mind as we're having our discussion. All right, so we are gonna, I don't see any questions from the audience yet, but we're gonna start with evaluation and management. So again, a few weeks ago, we talked about the major overhaul in E&M office visit coding, the first one in nearly 30 years. Let's see, Jen, I know you have some thoughts to share. I wanted to, before I turn it over to you, I wanted to mention, so I work for Charlotte Kohler, and she and I have been doing a lot of training sessions on these E&M updates. And we both also attended, it was virtual this year, the AMA Symposium. And there are some nuances that you might not catch if you are just reading the CPT manual, kind of skimming through it. You'll see that a lot of updates were made, but they might not be jumping out at you. So I'm just curious if anyone in our group, did you catch any nuances in the CPT manual? beyond just the code descriptions. Anything that you'd like to share? I'm going to keep rambling on a few I want to share if you don't, but I would love to hear from people. The first one that really jumped out at Charlotte and myself was the counting of unique tests. So with medical decision making and that chart where you have to, figure out if the medical decision making was, straightforward, moderate, whatever. They used to have you count unique tests based on if you ordered 5 lab tests, that just counted as 1. This year for the office and outpatient coding, it's based on the CPT code. If the CPT code is unique, it's a unique test. And when they announced this at the AMA symposium, the first time they did, we just assumed they messed up. We're like, oh, well, that was incorrect advice. Then they kept saying it and then admit, no, this is different from what you're used to. So the medical decision-making rules for the new, for the E&Ms that were updated are different from the medical decision-making rules that many folks are used to. So I just wanted to point that out. Jen, anything that's been going on at UMS where you've been kind of exploring the CPT manual update?
Actually, ours is really more with our system. So UMS is an Epic hospital, an Epic system. So we use Epic, and a little differently probably than maybe other hospitals, we don't actually use the facility charge calculator to calculate our E&M. So for those that aren't in Epic, our staff go in and they can document, what they're doing, if they're doing a risk assessment, if they're doing med management, or whatever types of tasks that equal their clinical care time, and then it adds it up and drops it. So we just have a lot of actually logic that we need to go back into the system to prevent that 99201 from being dropped. And a lot of what we're going to do is we're just going to force where it would maybe normally drop the 99201 is to force it to drop to the 99211. In Maryland, of course, same RVUs, same pricing. But, and then I'm going to put my other hat on for the clinic RVU task force. One of the things that we will definitely need to talk about, and I'm really looking for this group as well, anybody on here with particular concerns or things they definitely want discussed during the RVU task force. But, there's language in Appendix D today that talks about the attending only visits. And we're going to drive all of those attending only. So where it's really, they're using hospital space to see their patients. As much as we've tried to avoid that situation, it happens probably pretty frequently in some areas. And we're really just driving that to the 99211, regardless of whether it's really a new patient or an established patient. So for us, it's really a little bit more of that logic that had to change. The CDM kind of is the easier piece in this, but we have a lot of actual now clinical testing to do, and to make sure that all of that logic, we don't break something else. So what really kind of seems like it could be a very simple change in a CDM perspective has actually turned into a lot more work to make sure we're not breaking anything with our custom logic.
I think nothing's simple anymore.
No, that should be 2020. There was, and I don't know if somebody is going to address the chat, but I did see there was a question in there as far as related to these new CPT codes, and do we get RVUs from the HSCRC? And the answer to that simply is no, which is a lot of times where this kind of session kind of comes into play to sort of be able to talk through that RVU assignment, and that's technically what's called by report now, and you'll see some of those in Appendix D. I think as we've done task force, and please jump in, as we've been really redoing some of the Appendix D and various rate centers, we've tried to be very clear where that logic comes from. So for example, if you go to radiology, that is now pulling your RVUs from the Medicare physician fee schedule. So it's fairly easy to go to that schedule and follow that methodology to come up with your RVUs. And that was really done to make sure, or to try to make sure, all of the Maryland hospitals are kind of putting that same RVU in place. Since actually, it's actually, and I don't know if everybody knows that, it's a little bit harder to update Appendix D, that it actually does really have to go through legislation to get it updated. So, and I think, Lauren, you've been actually doing some work with them to try to get some of the typos corrected.
Yes, that is apparently a multi-year process, but we're working on it. So true. And Jen, thanks for sharing all of that, because the other important thing with evaluation and management is there's clinic visit leveling and there's professional fee visit leveling. So I think it's, more of the professionals that are kind of reeling from all this medical decision-making changes and trying to handle that. As Jen said, on the facility side, that deletion of 99201 really did have a decent impact on Maryland hospitals, because they might not have been seeing a lot of activity on that for professional billing, but they were seeing a decent amount for Maryland hospital billing because of that professional only service visit.
Yeah.
So,
and is a little bit different. We are very, right now we're very segregated, and my revenue integrity team is really, is hospital billing. And so we try not to, I try not to speak for the professional side, as well as I appreciate when they don't speak for the hospital side, because there are some nuances for both sides. And so, one of the questions I think you've kind of posed to everyone is, what's been the strategy for educating our providers? So from a facility perspective, that hasn't really played into anything for me this year. That's probably the one thing that we haven't had to address. But I'm not really worried about educating those providers. They have their own professional education pieces to that. And so really, the way we do that on our end is to, it's all through the clinical care time. So for the nurses or the various providers, for them, they're still following the same logic. They're entering what they do, and Epic will spit out their visit level. So that's been nice.
And this year, though, between now and July 1st, you can probably expect that the facility side's going to get hit in Maryland, depending on decisions made by the task force. So,
correct.
And as Jen said, really need people's input, because everybody's got to live with this.
We do, and I think especially with, if you think about price transparency, the facility fee disclosure, all of this that's coming up. I think one of the things that I have heard out there is there has been a request to try and perhaps hold clinic E&M charging constant for the year, so that it could be excluded from price changes, because I think as you start looking at estimates and what are we going to do, when facility fee disclosure is in play, how does that, what is that really, and taking a step back to, why are all of these regulations going into play? And it's really for the patient perspective. And, we do this for a living, and in some instances, it's pretty confusing even to kind of walk through these regs, but figure out the patient side who doesn't really understand any of this. So I think always putting that hat on it's really for the patient perspective. So I think if there's something that can come out that maybe the E&Ms are held constant and we don't get that pricing, we get a lot of issues from some of our reoccurring accounts. If you think of your cancer patients who come back month after month, and last month the price was this, and this month the price was this, and they don't really like the idea of a sale, or, that doesn't really work for them. So it'll be interesting what comes out in the next
Don't they know it's
months.
the end of a rate year period and the prices either have to go way up or way down?
Yeah.
Sure, that makes so much sense. I did see another comment come in, and yes, we will be talking about lab RVUs. So we'll be walking area by area to help folks as you're trying to update your CDMs. So Caroline, before we move off of evaluation and management, what kind of rumblings are you hearing from providers? Anything else? The conversion factor, that's been a topic of conversation. Anything you want to share there?
Yeah, exactly. So, with any time that we have a change in a code set, Jen definitely picked up on the pieces related to the system management of that. And depending on what systems you are, that can be, all different levels of complexity and not as straightforward. And it's really difficult sometimes to align these different changes to the point where when we're looking at our trends and and trending and monitoring and providing reports, especially back to the physicians, they're going to see a change. They're definitely going to see a change on the revenue side because of the conversion factor and the evaluation and management, but also related to their services overall because there was a decrease. Now, CMS said that the changes in evaluation and management, again, on the physician side, were to be net neutral. However, there's studies out there right now saying that certain specialties are going to take a hit because they might not have a larger volume and mix around E&M, so that it may be data that's a bit skewed. So the ramblings that I'm expecting, especially knowing a lot of folks here on the call may have some reporting responsibilities or insight into the provider side, is be expected to hear that from the physicians and trying to understand, maybe their RVUs aren't changing in certain areas, but the revenues are going down. And based on their physician compensation, for example, that's going to be a very real conversation. And that's something even for our financial leadership to take into consideration as they're looking at physician compensation, if it's tied to the revenue and off of RVUs, where that might not change on the provider side, but you're getting less money. So you actually could end up losing out on those arrangements. So we know physicians like to get paid. They're very passionate, as they should be. They're very much aware of their productivity, their reimbursement. So as that change, set the expectations and be ready for those conversations.
So true. And some studies have really shown that with the new medical decision-making changes that they made, I threw out that example of the lab test going from, you used to count it once and now you would count it more than once for multiple CPTs, that those levels may go up. And they increase the RVUs for the E&M levels to begin with. So payers are going to be responding because they're probably not going to just start paying more money. They're going to say, oh, well, I'm seeing a lot of 4s and 5s now. So it's going to be really interesting. We're at the infancy of this. It's been in the works for a couple of years, but there's going to be a lot communicated from the AMA, clarifying the rules from payers. So definitely watch out for that. And like Caroline said, physicians, they don't miss a beat. So they're gonna reach out as soon as they identify.
And very passionately, we'll put it that way.
Yeah. If their RVUs are going up, they'll probably.
I think it's more the concern outside of E&M. So on the surgical procedures and the specialists, where their other services and procedures have not necessarily changed in the RVU piece, but that conversion factor is now taking the reimbursement down.
Right.
So CMS was saying overall, when you take into consideration across the board the evaluation and management changes to increase those RVUs, that it would offset, but that's not necessarily what we're seeing. That's not the case. So it's something to be looked at individually.
Right. All right, before we move on to surgery, we got another E&M question. If we decide to base our E&M levels on time, how are other facilities documenting the time spent per patient, time studies, and then using averages moving forward? So Jen, this is interesting. This facility E&M leveling, where right now the clinical care criteria is based on time. We could see that change. But do you want to talk a little bit about, average versus time studies and things like that?
Sure, and I can tell you what we did as in our system. So we did do time averages, and I will tell you, we have not probably looked at them very recently, but it was a lot of work. So I'm not going to kid you on that. But we did try to average out amongst different clinics, those different tasks that make up clinical care time. So we really did how long on average was maybe an MA or a nurse spending doing vitals and maybe doing risk assessments or doing, all the various things that go into our clinical care time. So we did 2 time studies, and then we did average them, and we came up with basically an average, because one of the goals as of, we have one more implementation, but we will have all 14 of our hospitals on Epic. So really trying to use that standard application and standardize across the system. It makes life easier for really everyone. So we did take that approach. We were, whatever the time average was going to be consistent across the platform. So we did look at those time studies, and then we did create an average. And what we did is, and again, we've altered our logic so that we cue the provider in, so whether it's the MA or the nurse or whoever is involved in the care, to what that average time is, but we actually require them to fill in the time that they use, so that maybe this one patient was a little difficult and was above the average. They have a time box where they can enter in their time. Say this one took 10 minutes, but on average it's 5, or vice versa. So I'll tell you, there's definitely positives and negatives to that. Sometimes people just pick the default, and maybe it's way less than that. So that's how we chose to do it. I know for other maybe Epic hospitals that are actually using facility charge calculator, it kind of works on a point system, and you can use that point to be minutes or however you want to do that. But I think some sort of a time study is probably needed. And that's definitely, I don't know if there's anybody else out there that has done that a different way, but that was the approach we took as our system.
That's great. Yeah, those point systems can be helpful. You just have to be super careful and look at what the results end up being and make sure they appear reasonable. And in Maryland, I think when it comes to clinic visits, most folks have used time studies because of the way the criteria is written. So.
Yep. And it's funny, and as part of all of this, one of the things that I'd also like the clinic task force to take a look at, Maryland's, with residents. And I think in the Appendix D, it does say you can include resident time. And we've kind of, as a system, gone back and forth because sometimes those residents they're driving some of our patient complaints. Well, I only saw the doc for 5 minutes. Well, you forget you also saw the nurse and the MA and, some of that. So some of it is trying to maybe, again, put our hat on what's best for the patient. So the way we have our system set up, we actually, each of those time points, so how much time for vitals, how much time for this, are discrete data points. So we actually can run data and then look at, okay, how long is perhaps a PA that's not professionally spending doing this? How long is an NP? And we've had to sometimes adjust what we think, because sometimes we think maybe it's been too high. So although we have not really gone back to do time averages, we have had to pull those discrete data points and do some analysis on that. I know we're not talking necessarily about ED, but when you talk about the point systems, we do look at those. We try to yearly and even compare across the systems. We don't enforce that every hospital take the same point system, and Epic does allow you to kind of change that per system. But we do look at those regularly to say, are we still in line? Does this still make sense? So I think there is, when you do put some time estimates, you do have to do some due diligence to verify that something hasn't gotten out of whack or practices have changed. And so it's all very time consuming. But the data collection has been an interesting review. So I think it's definitely something that we need to talk about as a clinic task force, about the type of staff that are employed by hospitals and being seen in clinics. Because I think we get questions all the time about, well, can I include this person and this person? And, kind of going through a series of questions. Well, where's the cost lie? Are they professionally billing, et cetera? There's a lot of things, but I would definitely like to explore how other hospitals are using PAs and NPs and social workers, et cetera, et cetera.
Yeah, accumulating that information is going to be so helpful for Jen as she, helps lead this task force. So input like that is great. And I just remember in the beginning when the whole time thing came out, if the patient is requiring more time because there's complicating issues with the patient, that's one thing. But if it's my first day on the job and I'm taking 5 times as long to do so it's like trying to juggle all that. So I just remember so many interesting conversations like that. And even with residents, your less experienced ones versus your more experienced. So it should be some great conversation.
Yep. And there was a timing even in the year that we chose to do the time studies, that we didn't necessarily want to do them in July. We didn't necessarily want to do them in June because, July, you got your brand new residents, June, you've got your experienced residents. So it was finding that happy medium, so it's not an exact science.
Right. Well, great discussion on E&M. For those of you that are not attending those HSCRC Clinic RVU meetings, but would like to, they are public meetings, so anyone can attend them. You can get that invitation through the HSCRC website, maybe, Jen, or I don't know if they should reach out to Bill Hoff directly, or what would you recommend?
Yeah, or you can reach out to Bill Hoff, or you can even reach out to me, and I can give my email at the end.
Great.
Because I'm also looking for,
because you don't get a lot of emails, so
No, not at all. But I'm also looking for some volunteers to help with kind of just running some data and looking at some things offline, so that we just so everyone knows what the HSCRC is pushing for is this clinic task force will be done early spring, late winter, and that the conversion will take place effective July 1st, which means getting the commission data a month to 2 months out from that. So with it being early December and the holidays coming up, we're going to have a sort of a short time frame. So I think there'll be a lot of work done off meetings and brought back for the bigger group to discuss. So if you're interested and have some free time on your hands, I'll definitely share my email address.
And we know everyone's time is limited, but when you spend time working on the methodology, it's only going to make it easier for you when you have to implement it. So you can spend your time earlier or later in the process, basically. Yeah. All right. Okay, we could probably spend our whole time on E&M, but let's go ahead and keep moving. So surgery, with this group, we typically don't spend a lot of time talking about the surgical code updates. Most of those codes are usually applied by coders, HIM department. Typically, I mean, some might be hard coded in the charge master, but most would be soft coded. So before we just breeze through this slide, if there are any concerns from the audience on surgical coding, Caroline or Jen, anything you wanted to share? Didn't want to skip it, but I know that we typically don't spend a lot of time on it.
Yes, I know one thing I've been hearing is just with the changes with the inpatient only list, that there's some potential concern from scheduling, registration, and coding folks alike to understand if there's a difference in medical necessity, how are the payers going to relate to this, related to those items that are coming off of the list. And a lot of those, my understanding, are orthopedic based. And what they need to be aware of. So if coders hadn't in the past necessarily kept up to speed on those particular procedures and those codes, because they were all primarily pushing on the inpatient side, that's something that would be a list to take a look at and make sure that you have comfort in your coders, and if they need any re-education in those areas as well. It probably wouldn't be a bad idea on your physician side to do that as well, just to make sure, because those would now potentially, anything going to an outpatient basis, we know is a great audit target always. So if we haven't been paying too much attention on the documentation requirements related to those procedures, again, any of those requirements, just take a look back at those to make sure that you're covering yourself in the facility piece with the physician documentation, what the expectations would be.
Great points, Caroline. And just for those that didn't notice that, what Caroline's referencing, so in the final rule, and this was in the proposed rule, so they are looking to phase out that inpatient only list over the next 3 years. And this was the list that essentially Medicare said, these services we would not expect to be performed on an outpatient basis. We don't intend to pay for it on an outpatient basis. There can be some exceptions, but in general, that was their thoughts on those codes. And they are doing away with that and letting it be, at the discretion of the provider. So, like Caroline said, you have some pretty significant orthopedic procedures that definitely used to be inpatient, and now these patients can come home that evening and not be admitted. So from a hospital side, the billing then is completely different. The claim form is, of course, going to be very different. And instead of having ICD-10 procedure codes, now you're having to worry about, CPT and HCPCS codes for procedures that, again, the coders might not have been used to coding that way because they were mostly inpatients. And on the flip side, the ambulatory surgery center list, that's going up. So the services that used to be required to be in a hospital now can even be in a surgery center. So you see this shift from inpatient to outpatient, from outpatient hospital to surgery center. And, just something to really keep your eye on, because these are some very major changes. And again, these are services that 2 years ago, no one would have dreamt would be outpatient, and now they are. And so,
and I think, and we've gone through some of these, in the last, many decades and years about different procedures coming off the inpatient only list. I remember when they took pacemakers off the inpatient only list, and I thought, oh my God, you've got to be kidding me that you're going to do that on an outpatient basis. Well, now that's commonplace, right? So we all evolved to get there. But I think looking at some of these procedures, I'm still it kind of gives me, honestly, the willies. Some of these would be done on an outpatient basis. So even though CMS might be driving this, I think it's really a great time to have a conversation with risk management, your medical staff, to say, it's the difference between being able to do it and should we do it, to have that conversation. And even if CMS is saying, hey, you can bill it on an outpatient basis, you might have payers that their clinicians are coming back from their chief medical officers and their policies to say, we don't feel that that's safe yet. And one of the things that CMS is doing by pushing this out more to the outpatient is they want to see not who's going to take advantage of it, but who actually starts to shift that volume to the outpatient. And once they get comfortable with seeing that it's a safe place to have these procedures done, they're seeing the volume shift there, then they're going to start adding in some audit activity measures. I mean, right now there's a little bit of a grace period, if you read in the disclaimer and a little bit between the lines, that as this is being shifted back and forth, that you'll get some leeway as far as not having to have these items out there for requirements for the 2 midnight rule, for anything related to medical necessity and RAC at certain levels. So just tread lightly. I would talk to risk management, talk to compliance about how you want to handle this at your individual facility.
With everything moving to home this year, Caroline, I thought that surgeons would just send a kit to the patient and they could just,
probably by June we'll have
sterilize your kitchen or whatever.
Right. I'm not fascinating myself.
That is not funny, but somehow
I know. Somebody will hear. Facebook will pick up on that, and then next time you go, right, Siri will have it up on your list of your take-home procedure kit.
All right.
Oh.
Let's move to our next slide. Okay, imaging. The imaging changes were fairly light this year. Thank goodness, because last year I think they were pretty significant. CPT code 76145, and I mentioned this when Charlotte and I were walking through the changes on November 13th. This one threw me for a loop. I saw it, I read its description, I saw where it was in the CPT book, and I said, oh, okay, the AMA screwed up. Everyone can do that, no problem, because this is clearly a 77,000 RAD-ONC code, but it is not. And I know since November 13th, Charlotte and I did a lot of digging into the code. The symposium talked about it. Jen, I know you and I were going back and forth on it too, and you started doing some digging into it. Do you want to share kind of what you found? It was a little surprising, I think, not what you were expecting.
It was not. So we, definitely our team met with our radiology team. We go through, and it was definitely a very light year, which in the pandemic world, when we're all kind of swamped with COVID things again, it was kind of nice. But my team came back and said, oh, yep, the radiology team wants to create this 76145 for radiology and for nuke med and for this. And I'm like, it's a rad-on code. We're not doing that. So then I, started digging, and they did some digging, and actually found out that most of our sites use a third-party vendor for these medical physicist evals completely. And some of those departments even have their own rad-onc department, but that physicist is kind of separate in the radiology world than it's used in our radiation oncology group. And then even our the medical center, so our biggest one, we actually employ one through the School of Medicine, and radiology actually owns all of those expenses for the medical physicist. So it really does seem that it would be appropriate to have this code set up under multiple rate centers, perhaps, which is how we are planning to set that up.
Like
the one thing I think, yep. And then, the one thing, again, going back to, I think, some of our questions about how that RVU would be determined would really be based on whatever is in the Medicare physician fee schedule, which is per, what the Appendix D preamble talks about. And so it would then be sort of the same RVU, but it'll just have a different rate per RVU in Maryland for our different centers. But yeah, that was a little surprising to me. But that's what we have found out for our system. So it's definitely something to, if it's something your facility is looking to perform, is to really understand where that medical physicist is coming from, and whether you're using third party but where does that expense lie?
So Charlotte, so we've been going through these January 1 updates, and last night we were on a webinar teaching about the updates, and she said some things about this code, and finally the light bulb in my head went off, and I'm going to attempt to explain what she said. Probably won't be exactly like what she said, but it's what I heard. So these types of evaluations have always occurred on the equipment. They are checking how much radiation these pieces of equipment are emitting. They have to, for quality control purposes. That is not a new thing that has always existed. That is not what is chargeable. But what has started to happen is they will actually change the amount of radiation that's emitted for certain patients. And it's obviously very important to monitor that. And so the reason why there's now a charge for it, it's patient specific. It's not overall monitoring for the equipment that now we're going to just start charging patients for. This is very patient specific. And what did she say? Sometimes they just want to pump it up. They got to make sure that that they're doing things properly. And so she would agree with everything that you just stated, Jen, with the physicists, and then added in some of that information last night for me that was helpful, because she's like, listen, if you're reading this thinking, don't they just have to do this? I mean, they have to monitor the equipment. It's obviously very important that radiation levels are appropriate, and you're correct, and that is not chargeable, the quality control that's always existed. So, so we hope that was helpful. I haven't looked at the proposed physician fee schedule, and then the final should be in a format that we can use soon. Everything, if you're wondering if everything's a little late this year, it is. So CMS is trying to get everything out there in the way that they normally do, but considering how crazy this year has been, and as usual, they do not push the January 1st date for providers. So, so this is one of those years where you're going to be sliding into home base, right? New Year's Eve, wrapping up your changes. But hopefully that discussion helps you with the 76145. So when you're having discussions with your clinical departments, you'll have a little background information going in when they start getting all technical on you and trying to confuse you. So, all right, so that was not the only change. We did have the lung cancer screening CPT code added, the 71271. I'm assuming folks are just going to mirror 71250. Jen, thoughts?
Yeah, I think that's my thought. And again, I guess if
actually, if it has a point value in the fee schedule, yeah.
Right, and so that's sort of, we're trying to do some preliminary stuff now without having that final, the RVU values. So hopefully, because I'm trying to take off. We tried to finish our CPT code changes prior to the holidays. Because I don't.
Is anyone off now that we all work remotely, Jen?
And is that a thing?
Were we not emailing at 10 o'clock last night?
We were, but I'm trying not to do that over the holidays. Or I'm going to try to have a cocktail in my hand, and so that I try not to email when I have a cocktail in my hand.
And you do have 4 children, so I guess we'll allow it.
A little bit, yeah.
Which is why you keep a cocktail.
Definitely. So yeah, so I think, this is where, and I think, people can disagree with my thought process, but we try, so again, our system tries to get things in prior to the holidays so that our team can kind of take a break. Not everybody takes time off, but it's nice to be done. And then if we have any changes, we do them that first week in January so that we have things in place. And then if we need to do some tweaking, we can do that. So that's kind of our approach that we've always taken, so that nothing gets held up for, when things start happening January 1st, but that I really do we all try to take a break for a little bit.
Nice. So Jen is basically passing on some advice so that your employees don't hate you during this, that your CDM folks. So I like it. Some good management advice. All right. I didn't see any questions come in on imaging, so we're going to go ahead and keep on moving. Oh, lab. So there was already a request for lab. The excitement has been building where lab RVUs. Okay, so when it comes to lab actually does not follow the Medicare physician fee schedule or the lab fee schedule at this time. So when you have to set up a new test in lab, I'll throw out what I typically do. Jen, Caroline would love your input. So typically we would look at the list of CPT codes that do have RVUs, and if it is similar, if the methodology and the work involved on the facility side is similar, we would mirror those RVUs and document that. These RVUs were selected because this test is similar to this other CPT code. That is not always perfect because sometimes you'll get a really unique CPT that unfortunately does not have a peer. And that's when you have to get a little bit into the details. Well, how much does it cost? How much staff time, reagents, and try and figure out what is a fair price considering what your lab rate is and your rate per RVU. So that's my take on it. Jen, Caroline?
That's exactly what we do as well. And then we also use, because a lot of these, not a lot of these tests, but with things now being sent out to various outsourced labs, that's one of our determinations too. Are we doing it in-house or are we sending it out? And if it's sent out, then it is determining what are we being charged to run this test. I think we add about a 10% markup to that, and then we back into our RVUs. And, some people may do this probably a little bit more simplistic and kind of keep a spreadsheet of their by report. One of the things that we have done, and I don't know why we started this, but we actually create a separate Excel file. We have like a template that we follow for every by report we create. So in addition to having my team try to update and get all of the Epic system updated, the other responsibility is really setting up all of our templates for by report. And so it does make it easier when the HSC special audit comes around and they're looking for by report. We may send 20 files if that's what's asked for, but we do it so that we kind of have a distinct record for this CPT code. As codes are inactivated, we retire those by reports. We may create new ones. We have an effective date for the radiology ones that have, here's, we reference the Appendix D preamble language of where we created it. We also have learned to put in the specific version of the Medicare physician fee schedule we're pulling, because in 4 years, inevitably, we're going to be asked a question, and it's always nice to have that detail. So that's one of the things that is probably a little overkill for our department, but it has saved us in the long run. And we do the same thing for the labs. And with the labs, it may be, here's the cost, but Lauren, to your point, sometimes we've had to say, here's how much reagent goes into this. This is how much this costs. And we really lay out very specifically how we get to that cost, so that I do go back a little bit to radiation therapy prior to the clinic or the RVU task force, when we had some of these crazy new technologies and we were really trying to get to a set RVU that we thought it was worth, where we had some crazy algorithms in our by report methodology. So we've kind of done that same for lab. So some are very simple and some are much more complicated. Carolyn, have you seen different things?
Yeah, I think both of you guys have hit on the different pieces out there. Some folks look at the clinical laboratory fee schedule just more as a benchmark basis to make sure that, at the end of the day, their price isn't, 5,000 times over. Some type of reasonableness check is the only other piece I would add to that. And definitely, Jen, I love the diligence of that by report tracking. It might be a bit much, but I can tell you doing CDM reviews in Maryland hospitals, a lot of times people would set up things by report, and as codes did get developed or RVUs, they didn't go back and revisit that. And it would come out in a special audit or, a paid audit or review that was coming in. So having that as another check on your annual review, different pieces is probably a good thing for people to take away if they're not already doing something similar.
And both of you reminded me of two things to keep in mind too. So when HSCRC asks for your by report criteria, as Jen mentioned, maybe it's overkill, but trust me, the better your documentation is, and try and make it in sort of layman's terms as much as you can, the less back and forth you're going to deal with. So you did a little bit extra work up front, documenting the service. So now when they come back and ask for it, you're not getting a lot of, well, what does this mean? What does that mean? This doesn't seem right. Or this, you don't even have enough documentation. So it's one of those things, you're better off just doing the full documentation when you're in that mode, setting up that service. And the other thing to keep in mind, so with lab, if you're mirroring another CPT code, you're usually good. You can set that up, be done with it. But if you've done more of a challenging one where you looked at costs, that's something that you're going to need to revisit, because 5 years from now, those numbers might look very different. And all of a sudden your charge is way off, and then you get asked for the documentation and doesn't look right. So just something to keep in mind and maybe flag, okay, these are the by reports that I need to revisit each year. For lab, maybe they were based on cost. For another rate center, maybe they were based on time. I need to do a time study. I need to do a cost study, versus the ones where you mirrored another CPT code. You're probably okay with those, unless something crazy happens.
Very good points, Lauren. Yep, that is definitely something that goes
in your
on
spare time, of course.
Yeah, it's in that revenue integrity audit type of plan we have. Yep.
Exactly. I'm always surprised how much, in just looking at, in Maryland or outside of Maryland, just looking at how different reference labs will charge for things, even quarter over quarter, they can shift drastically. So depending on if you can lock in your reference lab on those costs and try to get on that time frame, or if it's more free flowing, that's definitely something on the cost piece that will shift the greatest.
Yeah, and we're not throwing that out saying that's an easy thing to do. We're just saying something to maybe have on your list. I've been working in healthcare since '97, and I can remember one time this really coming to bite me because it was a time study type situation, and so many years had gone by that the time didn't make any sense.
Right.
And, it wasn't intentional. It was just, we were like, wow, standard of care has changed so much. So that's kind of when the light bulb went off for me to look at that kind of stuff before someone else does, preferably.
I find sometimes, and I mean, at least I find that most lab directors like tasks like this. Like if you say, here's your list of things that we in the past have based on reference, can you have somebody look at that? Like I usually delegate that piece out, so at least get that heavy lift off of me to be able to do that, because obviously they have access to that data, and they tend to and get a little bit more hands-on, I think, than some of our other departments.
Yes, lab codes are detailed.
I would agree with that.
Diligent.
And I think, Lauren, you're correct. The laboratory piece is definitely something that you need to go back and look at. And then again, I'm going to plug the RVU task force for the clinic, because I think the other big area where time studies really come into play is ORC. And I know not every hospital has an ORC, that OR clinic, but I think that's another area where those time studies, if you're choosing not to bill by like minutes and you're trying to hard code your procedures, doing those time studies is a lengthy process, but the lab and the ORCIC are really the big areas. The good news is, I think with a lot of these, as we've been rolling out these different rate center RVUs, we've really have good language in there from a preamble perspective, like radiology and respiratory and all of those, where we're using a great methodology that's pretty well documented. So it does make the buy report, or creating those new RVUs fairly easy, but lab and ORC is kind of still out there. So
yeah,
so again,
for those of you new to the HSCRC manual, you will be able to tell, wow, this one is not very clear. That's probably an older, hasn't been updated recently. And then the ones that you actually can follow and have some guidance on your buy reports, those should be some of the newer ones. So there's definitely been an effort made to make it clear. It used to be, if you didn't sit on that task force, if you weren't at that meeting, you're reading it 10 times being like, this makes no sense to me. But there's really been an effort made to make sure that the documentation is as clear as possible. And if it's not clear, you can always ask questions. So whether you go to the HSCRC, check with another hospital, use a consultant, whatever, you can ask questions when it's not clear. And honestly, there's some things that aren't clear. So,
or readily available.
Right. And there are some where you could argue 3 different opinions and you'd all be right. So Jen and I have had many friendly debates over the years. I have also had those debates with my boss. And when I leave that conversation, Jen, I still feel like I'm right. So just kidding. You've turned me on some of them. Okay, so we're not going to dig into all the lab codes again. We did that on the 13th, but we hope some of this general information is going to help you as you're trying to set up your CDM or update existing CDM. And that same logic for RVUs can be applied with all this COVID stuff that's coming out. Yes, all these codes are new and this pandemic is a new situation for us, but keep in mind that a lot of the methodologies that they're using have existed for other diseases. So try not to panic when you have a new COVID test and try to think exactly the way we were just describing. That being said, there are a lot of new U codes that impact COVID that are pretty unique. So you're going to need to pull out all your tools in your toolbox to try and set these charges up with RVUs. Now, here's the confusing part. When all of this started, the HSCRC relatively soon after issued a memo that said, you can use standard RVUs, but price these services mirroring Medicare reimbursement. So if it's a locally priced service, mirroring Novitas; if it's a nationally priced service, mirroring CMS. Then they stopped providing those types of memos. Our team has definitely been in touch with the HSCRC, throughout the pandemic. And as far as I can tell, and here's your opinion disclaimer, opinion of the panelists, as far as I can tell, that is still how they feel about this. Use your normal RVUs, but try to keep your price in line with the Medicare reimbursement. The reason they're trying to do that, and you might already be figuring this out, is they're really not trying to draw attention to Maryland having exorbitant prices for COVID tests, especially because you have to put these prices on your website. So they're trying to keep Maryland kind of under the radar from a pricing perspective, but not blow up our whole RVU reporting system either. The challenge this poses, though, is that now you have these services priced with a lower rate. So then you end up having to raise your rate on your other tests to make sure you stay in compliance. So it's not convenient, but has anything during the pandemic really been convenient? I don't think so. So just to be aware when you're setting up something COVID related, kind of put that hat on. Hopefully we'll get some more definitive guidance from the HSCRC. I know, Dennis and I communicate fairly regularly, and I kind of said that to him. I said, Dennis, maybe you're just putting out a general guidance for all these new products and services, follow standard, RVU assignment, but try to mirror CMS reimbursement during the period of emergency. Has he done that yet? No. So again, this is opinion, not fact, but I'm hoping that that's the direction that they're moving in, so that at least hospitals in Maryland could be consistent. Because right now everyone's just kind of trying to figure this out. I mean, you have the preliminary memos, but you don't have updated information, and these codes are changing rapidly. Especially, I don't even know that we have a slide on this, but that U code situation where in January you'll have 2 U codes. One is an add-on code to the other. That's tricky. So hopefully we get a little more guidance from the state, and we're kind of partnering up, Kohler's partnering up with the MHA to help, the HSCRC and hopefully provide some guidance to hospitals. So let's see. We have a question that came in. Do you foresee the HSCRC updating the RVU and price for the COVID diagnostic tests that use high throughput technology? So this is the one, this is the 70, it used to be $100. Now it's going to go down to $75 reimbursement with a $25 add-on if you get the tests done within the time frames that are specified. So if you don't get it done that quick, you're only going to get $75. If you get it done quickly, they have all this like rules on how you measure that, then you get the full 100. So I would like to see the HSCRC issue some guidance on this one. In my mind, I'm thinking, again, try and stay with standard RVUs, but then you end up having to like split them between these 2 codes and then try and mirror the national reimbursement. But that is just an opinion coming from me. Have I said that enough times? An opinion, and you can't hold it against me when it doesn't go
and
well.
And Lauren, I think it's going to be important as we kind of try to talk to Dennis about this too, that as the vaccines and as infusions for treatments are, fast approaching and coming, that I think he's going to have to expand that beyond the labs as well. But, how are we doing some of these therapeutic regimens that are coming out? And it's, they were kind of quick to get on board with telehealth, and we can talk about that in a little bit when we get to our coronavirus slide. But I think even again, kind of just that constant communication, I think, with hospitals, because things are changing. And I know the commission is struggling to keep up with all of the changes as well. But the more that hospitals can be in sync, I think the better, sort of almost a united front to all of the patients in Maryland and beyond would really be helpful.
Yep, agree, 100%, at least be consistent. Nothing's going to be perfect, but if we could have folks, with consistent guidance. We did get a few more questions in, which is great. So there are some codes for which we have a price from First Coast, but not Novitas. Is it okay for us to go by the First Coast price till then? What I'd say with that is Novitas actually been pretty quick with pricing services, and they have a portion of their website where they've been putting all the COVID tests and the prices. So, I mean, if there's definitely not a Novitas price out there yet for a particular service, but you were able to find a reimbursement rate on another MAC, I think that's still going to be better than using your standard rates and having a price that might look super high for the test. But just continue to check Novitas because yes, the government moves at a different pace than the rest of us, but they've been moving much quicker during this pandemic to try and keep up. You know, FDA is approving things. Next thing you know, you have a code for it. Next thing you know, you have the reimbursement. So things are happening very fast. So if you're going to use a plug or a substitute, I would just say don't drop it after that, and then, you know, end up where Novitas price is significantly different from First Coast or whomever. And ask your peers in case you just haven't seen it yet. Dentists will reach out to me periodically and say, you know, have you seen the reimbursement rates yet for this service? And, you know, maybe the last time I checked, they weren't there. Now they are. So things are changing by the moment. All right, another question. Do you think HSCRC will possibly provide rate relief for lab? I'm concerned that the COVID tests are impacting the unit rate significantly, and we can't raise our test rates on the other lab tests without going over the threshold. Great question. So when it comes to rate relief and doing anything like that, you're going to need to reach out to the HSCRC directly. Show them your data, and they will work with you. But unless they issue a memo out formally that gives people permission to do this, you have to work with them one-on-one. Now, throughout this pandemic, they gave permission, you know, room and bed rates to go 10%, 15%. You know, they've done different things during this pandemic when they realize it's across the board and it's all hospitals. But for now, I haven't heard this come up yet. So I would go to the HSCRC about it before you run into an issue with being out of your rate compliance. It's better to talk to them sooner versus later. But great question. Okay, anything else on lab before we keep moving? Let's see how we're doing time-wise. Okay, it's a little after 10. Hopefully everyone's finding this morning's presentation informative. Again, please continue to type into the Q&A or chat box. Okay, medicine, 90,000 codes. This is always a mixed bag of services. So as you can see, it is a mixed bag of rate centers. This is when it becomes a little less straightforward. Let's see, Jen, Caroline, these are my guesses of where things are going to go and how they might be set up. Some of these rate centers have not been updated recently. Jen, you've been speaking about clinic. So this new retina code, if it even has a lot of activity, I know sometimes these services are happening outside of the hospital, but this new code will end up getting RVUs established for July 1st. For now, it would be based on clinical care time, right?
Yep, that would be my guess. Yep.
Yep. So, and this is a perfect example of why clinical care time is not a perfect. 1 minute of clinical care time is not equivalent to all minutes of clinical care time. And like, take this service, for example, I'm sure the equipment, this point of care equipment wasn't cheap. I don't know how expensive it was. But when we move over to a different weighting methodology, you'll see that start to work itself out, hopefully. Not that the RVUs are perfect that the government establishes, but they're probably better than just assuming a minute is a minute is a minute. So, because I'll probably say, oh yeah, that takes me 1 minute to run that automated analysis.
Right.
So, okay, VEMP testing. So this, I'm thinking EEG. Jen, Caroline?
I think it could go there, and I think we also have had a request for these in our speech department. So I think it's an interesting, it's kind of a little bit of an overlap, and so.
Thoughts from the group? Yeah, any thoughts from the group?
Yeah.
It's going to be driven by clinical practice here. Yeah.
Interesting. And if it's EEG, that one's been updated recently. So you can look at the fee schedule, I think, for that one. If it's going to be speech, speech is still pretty subjective.
Very subjective.
Yeah.
What's our last update in speech? Are we still talking like 78? It was.
No.
Did you just say 1978?
But I do think it was early 2000s.
Okay.
Like early 2000s.
No, it's funny because sometimes you flip through the manuals, you still see these older dates because they just haven't been updated. And I just giggle because I'm like, oh, look, 78.
Yeah.
Still going
Yeah.
strong.
Well,
Yeah, for our
here's a
type
little
A
fun.
folks, rehab is going to make you start like shaking. You're like, oh, which is kind of how clinic is too. We're getting there.
So here's my fun fact on this, though. I have maintained an old hard copy version of this HSCRC accounting manual that sits on a shelf, and it's probably this big. But the only reason I have kept it is because when somebody many years ago updated the actual document on the HSCRC website in Word, if you don't do your page breaks right, you overwrite all of the headers.
Yep.
And so that's why there is like a one date that goes through most things. But my hard copy version has the original dates of those task force in the header still. So
You could
anybody ever
totally
wants to
charge
look
like $1,000 for that. And
I
people
tried to do
want
that.
to order it.
I tried to do that.
Yeah, I'm going to talk to you offline. But Jen's
I
correct.
offered for, I actually have a copy. I have an old electronic copy that I typed up when I was still working in Annapolis. And I told Dennis at the time I had it, and then he went and paid somebody else to do it. So I think mine was probably cleaner. At least I had the right dates. So I had, like Jen did, I had a hard copy and I had an older electronic copy that we created ourselves.
So our public
tried.
service announcement to our attendees, don't trust those headers. They lie. And you're like,
do.
I know this didn't get updated in 2008. You're right. You are right. So that is too funny.
I haven't seen any comments come in on the VEMP testing. So if anybody disagrees or has a thought on that, I'd like to hear. But.
Yes, would love feedback on them. The AEP codes. So are those all falling in EEG? Because if they are, you don't have to worry about mirroring anything. I think you can use the fee schedule RVUs now for those since EEG was updated.
So universities we're always different. So some of those AEPs we actually have set up in speech, because I do think some of those might have been defined in speech a long time ago. Yep. We did run into issues with CPT, the 92585, which is being inactivated this year. We did have that set up double in EEG and in speech, because we have a a neurodiagnostic group that does some OR type of work, and it is a separate kind of department outside of the OR. And so we did have a little bit of, I don't like this, but it seemed to clear my issue because the code has now been inactivated, because it was previously defined only in speech. And now with some of those new codes, there is a specific CPT code, the 92653, that's being added, that is neurodiagnostic specific. So I think I have kind of, for me, I've worked out that probably that neurodiagnostic, we were going to move to EEG, but the rest of those AEPs, because they're really being done by our speech group, we were going to keep those as speech. But that's what works for our system.
That makes sense, though. Did I dream this? Is the newborn hearing screening still separately chargeable? Or did that ever get, or is it because if it's performed by EEG, it's separately chargeable, but if it's performed in the L&D, it's not? Is that the rule?
Yeah, so when done by the L&D nurses, it's part of the room rate. But remember, for some of your NICU babies, or they may fail a testing, and then you would either have speech and or audiology, and I guess you could have EEG. So if you're having to bring back in, and I believe from discussions that some of the hospitals were having to have a third-party vendor come in to do those services, so then that's when you would be able to charge for that service.
Thank you. I vaguely remembered that, but couldn't remember the nuances. Okay, and remember, this is the type of testing, the AEPs, where the patient can't respond. So a newborn or other situation where the patient can't respond to the testing like they would in other hearing type tests. All right, external. Oh, go ahead. Was someone?
Nope, I was agreeing with you.
External ECG, all these new codes. If you're doing those in a hospital setting, so the patient is obviously wearing this equipment outside of the hospital, but I'm assuming, maybe the hookup and takedown happens in the hospital. A lot of this is probably happening in cardiology offices, honestly. Jen, are these codes you're going to set up, or do you know yet?
We do not have plans to set these up at this time. I do think most of this is done in our professional office.
Yeah.
That
was my guess, because I know like a lot of the Holters are done that way, but where the HSCRC did land on this type of stuff, if the patient is coming to the hospital, and this is pre-pandemic, so I know everything's crazy right now with that, but their original rule was, if the patient presents to the hospital, it could be considered a regulated service, even though a lot of it was happening, the monitoring itself was happening when the patient was not at the hospital. So if you're going to set that up, just be careful. Make sure it's definitely going to be a hospital service if it was audited and not a Part B professional. All right.
Yeah.
So our last
section. Lauren, and just to add to that, I think just as a reminder that when if you're setting those RVUs up, that it would really only be the face-to-face time that's included. I know, to your point, again, everything's a little wonky right now with the pandemic, but as a reminder, the HSCRC is really about the face-to-face time. It's not what's done outside of.
But this one, if it's going to be under EKG, it's not going to be clinical care time, right? They would just use the physician fee schedule? Or what do you think?
I don't think the EKG was set up like that. It was really, I think, the task force prior to us going to the Medicare physician fee schedule.
Oh, okay.
So I think you have to base it on a similar service.
I think you're right. Yeah.
And I believe loosely it was based on time, if I recall.
Mm-hmm.
That it was, loosely, because I think where did we land? Like an EKG tracing was 12 RVUs, which I think was loosely 12 minutes, and where we came with 12 minutes. But if I recall, it was loosely based on time.
Yep, that's ringing a bell now. And the 1 RVU added for contrast.
Yeah,
we're showing our age now.
I know.
What'd you say, Carolyn?
So we're starting to show our age now. We start talking about
Jen's got that
we've been through.
Jen's got that book on her shelf, so she probably reads it every night.
Double sleeping, Jen.
We did all read that actually last night to prepare for this morning.
Oh my goodness.
Before we move on, did you see the questions in the chat? Okay.
Yeah, we got a few good questions. All right. What about respiratory panel tests that include COVID tests? They all have HSCRC RVUs, but the pricing is high when you multiply the RVU by the unit rates. So, Jen, I'm going to throw an idea out here. I want to see what you and Caroline think. I would still err on the side of using the national reimbursement. If it's at all COVID, play it safe.
Yeah, I think that's the key word there. Yep.
I agree.
But yeah, I'm sure the price that should be charged versus the price that is being charged, there's quite a significant difference. So which kind of goes back to that other question, what do you do when you can't raise your lab rates up any higher because you have a high volume of COVID tests? Mm-hmm. Okay, sorry to go back, but could we restate the piece about audiology charging for newborns? So I will try not to butcher this. If the newborn hearing screening happens in the L&D unit by an L&D staff person, that is considered bundled, not separately chargeable, whether it's L&D, OB, whatever, the maternal health area. On the other hand, if staff from EEG or staff from speech, or like Jen said, if there's an external provider that's being reimbursed maybe by speech or EEG departments, that's when you'd be able to charge separately. But you can't have the costs in L&D and charge, L&D or OB and charge for this. What do you think? Did I butcher it?
Nope, you did great. And I think it's that initial because if I recall, the state requires an initial hearing screen. So it's generally that initial hearing screen that is done, you know, kind of first thing. And then it's if that, yeah, and that's what really shouldn't be charged. And it's anything that comes back abnormal or you need to repeat because there's an issue is then I think when you can get into the charging situations.
Yep. Agree. Caroline, anything to add?
Nothing to add. I think we're good.
Okay. All right, we've got about 10 minutes left before we start having some fun. Not that this has not been fun, because I've really been enjoying myself. So hope you all have. Respiratory. So not a ton of like additions and revisions in respiratory this year, though they did several deletions. So let's start with the revision addition situation where it added the exercise test without ECG recordings. Respiratory, having flashbacks to those meetings is based on the respiratory system of weights, which I think is time, isn't it minutes?
It was loosely time. Yeah. Okay. And that's the reason I know that the EKG tracing was 12 RVUs, because I have just recently looked at this, because I think the 946, I'm going to butcher that, but the one that includes the EKG, so is that with 94617 includes the EKG? And I think that's set at 71 RVUs. 21. So 71.
Oh, 71.
So
yeah, that sounds right.
Yeah, so we were kind of trying to back out of that if that's roughly 71 minutes. Our clinical folks have said when you don't do an EKG, it's about an hour. So that loosely takes down your 12, you know, if you 12 minutes for your EKG, what's that bringing down to? About just under an hour. I can't do the math. Even
literally like 59, yeah. Right under, yeah.
So there's your mathematical formula if you'd like to use it.
Yeah, so I would say as long as you're coming, the 94619 should be less than the one with the EKG recording.
You know, the HSCRC would love that you used a value from another section for the EKG. They could trace it back within their own document. So how could it be thrown out? All right.
As a helpful hint, I do find when I provide the HSCRC and auditors with too much data, they generally sound like I know what I'm talking about, and they let us go. So,
give them that manual. They see.
That too is very much opinion.
On page 573, paragraph 2.
Yeah.
Yeah. Again, these are the opinions of the panelists, and you cannot use this against us, it's just our opinion.
Yep.
We're allowed to have opinions. Okay, so when it comes to the deletions, we did receive a comment that 94770 was in use by this hospital, and they were just curious if other hospitals were using it and what they're going to do now that it's deleted. The symposium said they took this one away because people were not using it correctly, which is very interesting. It's very interesting disciplinary method, because I'm thinking if that was the case, then tell people what to do differently, but not just take the code away. So thoughts from the group on 94770. Jen, have you come up against this?
No, and we didn't get a lot of pushback from our from our departments about getting rid of that. So, and I honestly, I can't remember right now off the top of my head whether it was a high volume code, but and actually, Lauren, I did take your advice. I listened in on the symposium this year, and I did actually find if anybody can, it was nice not having to pay for travel for doing this. But it was actually very interesting. It was a lot of information. But if anybody can ever participate in the symposium, I do think it's an enlightening process.
It really is. You're exhausted by day 3. It's so much information. Some of the speakers are super engaging, funny, giving you all kinds of stories. Other speakers, unfortunately, are reading the CPT manual as if it was a bedtime story, and it's working because you're getting very sleepy. But anyway, regardless of the speaker style, the information is all amazing.
But to the question that somebody did say, yes, there are currently 40 RVUs set up per day for the 94770, and that is being deleted for 2021. So it will be no longer accepted as of January 1st, just to confirm.
Did you just not have a lot of usage on that, Jen? Is that why you're not too worried, or?
You know what, I mean, it's been set up in all of our hospitals, and we'll have to go back and look at volumes again. I do believe in conversing with some of our respiratory therapy, and truly, I think our respiratory therapy teams are extremely busy right now. So I'm not sure they're kind of even reacting to what this possibly could mean downstream. So we probably just need to recircle back to them. So I don't actually have that information right now.
I was going to say, and I see somebody just put a comment in, from what I remember in respiratory, but this was a common code that was typically found in the edits, that it was bundled in. So a lot of people just struck it because of the complexities of trying to operationalize it in the situations where it would be captured separately.
Yeah, so thank you, Colin, for reminding me. Colin's on my team, so
Gotcha.
Thanks. So that is why we don't have a lot of volumes on it, because it does hit with a lot of CCI edits.
Mm-hmm.
So it may be used a lot.
That the staff are doing it, but it is bundled into something else. So that might be what they meant. We're taking it away because people were not using it properly.
Yeah, and they may not have been hitting the edits, depending on, I'm not making an assumption, if it was primarily inpatient involvement, they might not have seen that.
Mm-hmm.
Correct.
And in Maryland, this is tricky because when we set up our VUs, again, we were basing it on the time for each service. So sometimes you do end up getting hurt by some of these edits because, okay, you're saying this was bundled into that. We didn't necessarily set the RVUs up that way, but honestly, at the end of the day, it's often not worth the headache of trying to fix claims and fight for money, especially under global budgets. So.
Correct.
All right, so hopefully that helps folks that are struggling with 94770. If you do find that it is being provided and it's not being provided with another service that it's bundled into, and there's just no code out there to report it, remember that you could use an unlisted code. Now that comes with its own bag of tricks, but anyway, it's something to consider if that's your situation.
Yeah, and we've been seeing a lot of denials and edits on because in the Appendix D, there are a lot of codes with the 94799, and they do butt up against MUE edits. And so just, again, keep that in mind. We have started to see some issues with multiple unlisted codes.
So true. All right, and definitely a problem in respiratory.
Yeah, and I think just that comment, so yeah, so there is not a one-to-one replacement code for the 94770. If you need to use one, the suggestion would be using the 94799.
Yeah, but double check first to make sure you're even supposed to be reporting it. Okay, all right, we just got a few minutes left before we turn over to some fun. Luckily, we kind of touched on coronavirus when we were talking about lab. So again, our general advice right now, unless you hear something differently from the state, is try to stick with your typical RVU assignments, but pay close attention to your prices. Try and stay in line with what's going on nationally, and then hopefully there'll be some guidance so you're not guessing. You're doing exactly what the state has told you to do. So hopefully that guidance will come sooner versus later. Before we dive into some of these other concerns, just want to mention that you'll notice today we focus on CPTs because of the delay with the final rule, and but there could be some hick picks curveballs coming your way. So keep an eye out for those. Remember, CMS will sometimes set up a code because they don't like the way that the AMA set up a code. And usually each year there's at least one that drives you a little nuts until everybody gets on the same playing field the next year or two. So watch out for those. Use your network if you're trying to bounce ideas off of folks and figure out what to do. Caroline, I know you want to definitely share some thoughts on pricing transparency.
Yes,
I know we don't have a lot of time, but
I'm not going to go into a lot of, I won't go into a lot of detail. For those of you that are still holding out for a delay, I hope you get started today. And there's not going to be a delay that's forthcoming. CMS has their next open webinar session December 8th. That's next Tuesday. I believe it's at 2 o'clock. You can find that information on their website. For some reason you cannot locate it, shoot me an email. I will send you over the link that provides for presentation. They're going to reiterate the requirements around pricing transparency. Been in touch with CMS to understand it is not to announce the delay. So again, if you're thinking that call is going to announce the delay, it's not. It's going to reinforce the requirements. But this type of call forum that they have, they will also have an open Q&A session. So if anything, when you first log in, have your questions ready and know what star function to hit to get in queue, because they are very strict on their time and don't like to go over. So a lot of times questions are left unanswered. If you have specific questions on some of the nuances around pricing transparency, you've reached out, gotten conflicting answers, I will say CMS is doing a great job answering emails directly from both consultants and providers, which is odd on the consultant side that they'll answer us a lot of times, but they've been doing a really good job. Very direct questions. They'll come back, the best that they can. Don't be surprised if sometimes in typical governmental fashion, they'll say, well, look at the reg, and cite a different piece of it. If you're looking for an interpretation, be very clear on what you're asking for. So that's basic update. Full speed ahead, get some more information, and Godspeed to everyone working on this, as well as your CPT code changes by January 1.
And there's a lot of presentation. Oh, go ahead, Jen. I'm sorry.
No, I was just going to add, and if you're using Epic for your pricing transparency, yes, ask questions, because we have dug into some of their logic has not necessarily made quite sense. So make sure you're asking them questions and keep pushing ahead if you're an Epic user.
I would say that for any software solution,
yes,
stink test that data, make sure what's coming out seems right. Looking at it the old-fashioned way versus the automated. There are a lot of sessions. Caroline, you highlighted the one, you said it, what day is that?
It's next Tuesday, December 8th.
Okay, December 8th. So
that's Medicare.
Every few weeks on Tuesday night, there's also the office hours call with CMS. Joining into that can be very enlightening on COVID type questions. So that's super helpful. There's also a MedLearn Matters on the fee schedule. Looks like that's on the 10th. So that would be good if you have any questions on that. There should be something similar being set up for the outpatient rule. And then Novitas is doing a lot of trainings next week too. So, look on those websites if you're not getting those emails, and see if you can listen in, even if you're multitasking, updating your CDM while you're listening to these people talk. It's just in case they throw something out where you're like, did they just say what I thought they said?
Yeah, I definitely learn more in the Q&A sessions than reading anything on a lot of these different pieces, because it really puts, sheds a light on the situation a little bit more.
So true. So, this is the time of year, it is crazy. Like Jen said, enjoy your holidays, but expect to be a nutty person up until then. And then just a few administrative announcements as we go ahead and shift from technical to hopefully fun. We know you're all busy, but would love it if most, if not all of you, could stay on for this event and be our guinea pigs and tell us if you liked it or not. And the reason we say that is we're going to start using, virtual networking at other HFMA events. So again, we're begging you, but do what you must. Evaluations. We would love for you to fill out an evaluation for today's session. Also want to mention a few upcoming sessions. So next Friday, the 11th, is an entrepreneurship and innovation event. This is brand new. This was actually something that we were going to try to do before all the craziness set in, and we're finally able to do it. So we hope a lot of you will tune in for that one. And then in January, the HSCRC Workshop, which was always Maryland HFMA's most attended event. Great time to see everybody. Unfortunately, it won't be in person, but there will be virtual sessions being offered in January, and we're hoping that members, again, just like we tried to do with this event, can still get the benefit that they need. The plus side, you don't have to travel anywhere, you don't have to go to Martin's West, but still, keep an eye out for that. And there's some other events coming up again after that too. For those of you that are CPCs and you were looking to get CEUs for this morning, you are in luck. We do have those available. My contact information is on the screen. So feel free to shoot me an email. Full disclosure, it will take me a few weeks to get that certificate to you because I'm going to take Jen's advice and I'm not going to work on certificates on Christmas. So it's not happening.
Perfect.
Just to answer some questions that came in from participants. We appreciate the positive feedback that we're getting from some of you. Thank you so much. Jen, someone's asking about the CPT code for the Regeneron product. That's the one that's stuck in the middle. It's been FDA approved, but no code yet, correct? I haven't seen one yet.
Nope, we keep looking. So if we find it, we'll let you know. But I think we move forward with trying to just set up a generic code for it. Moving forward with just the normal infusion or injection codes.
And just tracking it.
And then
so remember, things are moving fast, but not always as fast as they need to.
It might have came out yesterday. I'm seeing a message that it might have.
Nice. Okay. If Christine, if you could share what that code is, we'll announce it. Another question is, hold on. We were talking about all those meetings coming up and some folks wanted a little more information on those links for the calls. So yes, we'll go ahead and have Holly send in a follow-up email where you can find out more details to sign up and attend those calls. Again, most, if not all of them are public calls. So if you have the time, it's well worth it.
Yep. And then Lauren, the question about the prolonged office visit, 99417, I think, again, this is a great conversation for the task force because generally we've kind of capped them at the level 5. So I do think that's something we'll need to discuss as part of the task force because generally we've sort of said it's level 5 when you hit that level 5 and above. But I guess we would need to really talk about how we want to handle that from a task force perspective.
I would agree. And for now, again, opinion, not fact, probably would not use that code on the facility side, would and use it only sparingly on the professional side. Prolonged services are audited heavily. It can be tough to get reimbursed for them. So that's a service that I wouldn't probably load into the CDM.
Unless you'd like doing ADR.
Yeah, and when we send this out, I'm okay if we include my email address for anybody that wants to participate. It hasn't been included in the clinic review task force who wants to try to maybe participate in a little bit of the smaller group as well.
If you're okay, Jen, we'll put that in the follow-up email. If you're okay with that being blasted out like that, unless you just want to announce it today. And
no, I'm good with that. That's fine.
Okay. All right. Well, I appreciate, again, the positive feedback that was coming in. We look forward to seeing the evaluations. We're glad folks got something out of this morning. That was our goal. We really had no idea what to expect with it being virtual. So thank you all so much for the comments, the questions. We are now going to change gears. So we are going to end our formal educational session now, and Caroline's going to gear us up for our scavenger hunt.
So Kalita, how are we keeping this as, there we go. our Zoom queen. So what I was going to say is if it says we haven't had a break since 9, and I myself had too much coffee this morning. If we want to come back at 10:45.